Right. Well, I must say, it's always amazing to see so many people on a Saturday morning. Just not getting out of the shopping or something. It's always difficult to know what to call the things that I do. Sometimes they're called by what they're not, which is non-pharmacological. But it's always very odd defining something about what it isn't, rather than saying what it is. I guess so self-management has started to become a term that's becoming more preferred because because it actually says what you are doing rather than what you're not doing. In case you want to find out more about this, and Fiona Blythe have written a review of self-management and evidence for its use in people with chronic pain, and published last year, and if you want a copy of that, I'm happy to provide it. So I thought I could start with a case. So this is John Everyman. He's got a history of spinal pain. He's had a tumour. He's had it removed. He's had radiotherapy and chemotherapy. But the pain has persisted for 18 months after this. He said he's spending most of his time at home. He can't go to work. He's going to a lot of appointments, ongoing treatments. But just about everything he does is restricted. He tries to do things at home, but again, pain is restricting and actually makes it worse. Well, it actually gets worse when he does try to do things. He's had so many investigations. He's seen so many different types of therapists. All sorts of medication, as we've just been hearing about, seen lots of people, but he's still got persisting pain, and he's still in this state. He's not been able to go to work, and even the idea of going to work is a bit of a problem because there's the boss, and he's wanting to know when are you coming back. I mean, it's amazing. He's still got a job, perhaps open. He's probably a very good employee before, and so they've tried to be helpful. But his workmates, they can't understand why he's not back. He's over his cancer now. He's finished treatments, but he's still got pain, and no one seems to be able to explain it. And he also wonders how is he going to be able to do his job with this pain. And he's of course worried about the financial implications. So these things are clearly weighing on him. And he's got a family, but there he's worried about his future as a dad, as a husband. He's worried socially. He can't go to things that we take for granted, like going out to restaurants, because he can't sit long enough for a meal. And he loved going to watch sports. He comes from Melbourne, so he liked going to the Australian Open, but he can't even go there because of the long hours of sitting. So his whole life has really become quite disturbed. He's become quite depressed. He's got a lot of beliefs or fears. He worries, well, why is the pain going on? They tell me I'm fine. Why can't they fix the pain? Have they missed something? Worrying about, is the cancer coming back? And of course he's depressed, he's worried, and he's got sleep disturbance, and his image of the future is this, being kicked out by the family, and even the family dog, sort of getting a bit sick of him. So this is all going on. So he's wondering what is happening, and unless the pain is fixed, I've got no cure. There's no future. So how might we help John? What are our options? And I'll give you a clue. It's very unlikely there's a single solution. We would love there to be one, but so far we haven't come across it. So what do people say about managing chronic pain generally? And these were practice guidelines, as you can see, from the US. And one of the key things about chronic pain has been this realisation that we actually are unable to cure it. And in fact, repeated attempts to try to completely relieve persisting or chronic pain can become part of the problem with iatrogenic complications. When the opioid problems are sort of obviously characteristic of that. But there are lots of other treatments people bash on with very little evidence. But there's obviously a desire to optimise pain control, while accepting a pain-free state may not be a sensible goal. And Jane Ballantyne and Mark Sullivan from the US have written about not chasing pain as the goal in treating chronic pain for these sort of reasons. But rather focus more on functional abilities, helping people get back to activities. Psychological well-being are also important. Enhancing quality of life, and of course minimising adverse outcomes. So those are some guiding principles that have been recommended in the light of the realisation that chronic pain is a reality. But the question, of course, is, well, all right, it's very well, it's like motherhood statements, but how do we actually do this? Well, the Americans are very helpful people. They've come up with some ideas on this as well, with another one of their task forces for the rather ambitious title called Relieving Pain in America. But in amongst it all, they concluded that ongoing self-management by those with chronic pain, supported by their health care providers, was the best option. Well, not just an option, but the best option. It's really the only option I would maintain for chronic pain, because we cannot resolve it. We can't do it ourselves, whatever our discipline. The patient's got to play a role. It's inescapable. And that's what I mean by self-management, the role played by the patient. How do we define it? Well, I'll save you reading my article, but you can. There are many definitions, a lot of other terms like self-care and so on, but the key thing here is the patient is expected to play an active role, not just sort of lie still and so on and have things done to them, but rather they've got to do the doing. But this can range from adhering to prescribed medication. I would see that as a form of self-management, because we know that at least half of patients don't adhere to their regimens. So if the medication is appropriate for them, it's obviously sensible to try it, even to give it a trial. If they've hardly taken it, it's hardly a trial. So, but it also includes, obviously, exercises, meditation and so on. But they all involve the patients being the agency. However, it's also important to realise that the goals here have got to be, if it's going to happen, one thing we know about adherence is that people won't adhere to something they don't think is going to produce the results, understandably. But those goals can't be our goals. The goals have really got to be those of the patients. Now, they will have the goal of pain relief pretty universally, and it's our job to help them realise that there's more to it there, because they've got to be prepared to work on these things to get to where that they want to be. And so it's not about... I'm moving the goalposts away from just focusing on pain relief as an end in itself, to saying we've got to accept that's really not really going to be achieved, but we're trying to shift it away from, well, what other goals might there be? So now a key framework in working with people trying to use self-management as part of your armamentarium is called collaborative care. And Michael von Korff wrote a nice paper about this back in 1997, so 20 years ago. So it's not as if this knowledge hasn't been around. This is really the key for self-management in people, in sort of cancer survivors particularly here. It involves the providers and the patients doing things. So it's not just telling patients you're on your own, you get on with it, nothing more we can do, but rather being prepared to work with this person, but not on the person. It involves having shared goals. So you both got to come to some agreement on what the goals are. You need a sustained working relationship because it's chronic. It's going to last a long time. And they may be the heart sink patients, but you've got to work with them. You've got to have this relationship, as in any chronic disease management. But importantly, there's got to be a clear understanding between you of your mutual roles and responsibilities, what you can do, and what you expect them to do, and again negotiate with the patient on what they expect you to do, being realistic about what you can and can't do. It's often threatening, I think, for medical practitioners particularly, who are brought up with the belief that you're very good at everything, you can do things to people that will work. And suddenly you've got to accept, I can't. It's not, that way isn't going to work. I can't just reach for the script pad. I can't do injections and things. I've got to actually listen to these people and try to help them. I've got to be more of a sounding board, reflecting, helping them interpret information that they might be reading in the media, and being an authority, a source of information, but also someone who can show empathy and understanding and so on. But the patient has to accept that too, because if they keep saying, have you got something else? I mean, I've heard doctors say, look, try this and see how it goes, and if it doesn't work, I'll see what else I've got up my sleeve. It sounds like it's a conjuring trick. I thought medicine was supposed to be a science. You might be able to go to the Easter show and see some of that conjuring trick stuff, but this is supposed to be done in hospitals, not at the Easter show. So we shouldn't be talking about what's up our sleeve. We should be working in a logical way, a rational way, in a partnership role with our patients. And that's what collaborative care is really about. But it does entail having skills, more than just being able to diagnose, more than knowing about what treatments might be appropriate and doses and so on. It actually involves skills in working with people. And so this, of course, goes along with an understanding of chronic pain and the sort of mechanisms that contribute to it. But the patient has to accept this active role as well. So there are many caveats to self-management that without these, then self-management in this context is unlikely to work. And it is true, people can work it out for themselves, and many do. They don't really need us, and that's obviously great. But if we are to help someone, these are the sort of things we need to think about. So I often point out to the patients that getting the doctor to do the exercises isn't actually going to help them in a lot of ways. Because often people say, oh, it sounds great in theory, but I don't think I can do it. But that is the task. You've got to be able to do stuff. There's no point in me doing it if they're the ones who've got to do it. So as in any chronic illness, we need to get, firstly, also an agreed understanding of what the problems are. Initially the patient just sees it as pain and has ideas about why it might still be there, despite being told, there's nothing on the PET scan, they're clear, so why is the pain there? And we've got to be able to explain that. Fortunately, the IASP, the International Association for the Study of Pain, has just agreed with a new term to account for a lot of pain that we couldn't explain, and that is we've had nociceptive pain. Gavin talked about that around the surgical period, and then we've had neuropathic pain, and we know a lot of people after radiotherapy and surgery do develop neuropathic pain, where you've got clear evidence of a nerve lesion. But then there are a lot of people where we don't have that evidence. They have a lot of similar symptoms, but we can't, now they've tightened up the diagnostic criteria for neuropathic. We can't really call it neuropathic, and it's no longer, there may be elements of nociceptive with inflammation and so on, but there's this big group in the middle we've had to sort of fudge. But the new term that is actually proposed originally, I think, or the person I think could claim some credit for it, is Dr. Milton Cohen, or Professor Milton Cohen at St Vincent's Hospital, who proposed this term nociplastic. And that has now been accepted by IASP as sort of the third mechanism, a term for this big group of people. But there's still criteria for it. But you don't have to have evidence of nerve damage any longer. That's for neuropathic pain. So it's where you've got similar sorts of symptoms of sort of central sensitization and so on, that you can refer to this as a mechanism. The changes going on in the central nervous system, and help patients to understand that there's the activity coming up to the brain and activity coming down. And it's those mechanisms which are clearly, we think, of course, playing a role. And I think later on, some of our research team are going to talk a bit about that area. If we're using a biopsychosocial framework, which everyone sort of says they adhere to, looking at the biological, the psychological, and environmental, social sort of framework in which people live, which can explain a lot of our behaviour, including the behaviour of people in pain, then we need to try to explain this to the patients. Because simply saying, try this and see if it helps, is not a biopsychosocial intervention. It's really a very traditional interaction where the patient is playing very little role, other than sort of adhering to the regimen. So it involves us in communication skills. So this is where you see, I hope, that self-management is more complicated than we thought. It does involve us as well, healthcare providers. But there is actually good evidence that if we can get good at this stuff, we'll actually get better results. So, and that's been argued for quite a while. This is a nice article in the British Medical Journal in 2002, where they, so it's been a topic for a long time, but they, Maguire and Keithley have written for a medical audience about these sorts of things, where communication skills are critical to the management or care of patients. And the sort of benefits attributed to better communication are improved accuracy of problem identification, you get agreement with the patient what the problem is, greater satisfaction by the patients, but also, importantly, better adherence by patients to advice on behaviour change, which is, if we're talking self-management, then obviously that's important. So it does seem important that we do take communicating seriously, and that area has really mushroomed in recent years. So that's good to see. But we still see people making, and we all do this, make these errors. We don't explore the patient's beliefs about what they think is wrong. We tell them what we might think, but what do they think? How much do we tease that out? And then when we do give an explanation, do we refer back to their beliefs to sort of be able to sort of provide an alternative account? We might just say, no, you may think that, but this is what I think. But then you've got to explain, well, why might they think this? How might what you're saying fit in with what they're experiencing, and might challenge some of their beliefs? And then finally, we often don't check whether patients understand what we're saying anyway. And what we do is say, do you understand? And there's only one answer people around the world give. If you ask patients, do you understand? What do they say? Yes. And I've asked this question in multiple countries around the world. I've had exactly the same answer. And the answer to the next question is always the same. Does that mean they do understand? No. So it doesn't matter whether you're speaking in various types of Chinese or Vietnamese or Greek or Arabic, you get exactly the same responses. So we need to, so it's not that complicated, but we just need to be aware of this. So we need to employ active listening skills, which really reflects the fact that we've listened, we've given feedback, we clarify we've actually heard the patient by paraphrasing what they're saying. We also check whether they've understood us. We can multiple media. Not everybody responds to oral information, to simply telling people, in one ear and out the other for a large proportion of people. But sometimes you've got to write a picture, do a diagram of things and hand it to the patient and to summarise what's gone on, and they can take that away. Or there may be written material as well, of course, you use. So it's important to use as many as possible because not everyone will take information in the same way. So lectures, we've learnt for a long time ago, are a very poor way to transmit information. So what are we doing? We're giving lectures. Because it's easier for the lecturers. So don't do as we do, do as we say. We do actually have to know a little bit about what we're talking about, but we also have to be careful not to say pretend we know too much, and acknowledge limitations, and say also there are a lot of things that are puzzling. There aren't clear explanations. Maybe we can get an opinion from someone else and so on. So people respect that, people knowing their limits. But also indicating that you're willing to work collaboratively. And this is the body language, sitting across the desk from someone, telling them what to do, handing across a script is not collaborative care. It's harder to do it that way. It's better to be sitting sort of around the edge of a desk, so you've got something to lean on or write on, but there's not a big barrier between you and the patient, because you're trying to be open to the patient and show you're accessible and so You need to think about your body language in the consultation. So the key messages with chronic pain are this term validation, which is really just indicating to patients that we accept they're in pain. It may seem trite or sort of obvious, but with chronic pain, particularly where there's no clear biological basis, although now you can use this nociplastic term, which sounds very good. It sounds like we know what we're talking about, but of course we have a label. But it's better than fibromyalgia or something. And it's but it is important that they don't feel they have to keep proving to us they're in pain. That's the worst thing to happen, because you can see how bad it is, doctor. As if the task is for them to show how bad they are before we'll do something, when the reality is we can't do anything. We've got nothing to offer, really, other than risk of making them worse. So it's very important that we don't get them into feeling they've got to keep proving their pain's bad. We accept that's difficult. And differentiating between chronic and acute pain is always seen as important. Just simply identifying acute pain is a very useful sort of pain. It tells us there's something happening. Whereas in chronic pain, we've got these other explanations, fault in the wiring or whatever you want to use, and whatever you think your patient could comprehend. And there are a lot of metaphors and so on that are used to describe the sort of what might be, or to help people understand what we mean by chronic pain. Where you've got pain, but it's not a new damage. It's a reflection of the previous damage that's been sustained by various ways. We can talk about central sensitisation. And I often use the sunburn analogy for central sensitisation, pointing out this with sunburn it's peripheral sensitisation. Fortunately, that goes away as the sunburn resolves. But in central sensitisation, it's in the central nervous system, and that doesn't seem to resolve like sunburn resolves. So that's and most people in Australia have been sunburned, so most people can relate to that experience. Of course, the patients in this case are often worried that the pain means cancer recurrence. But it's important to see that's not the only explanation. It's possible, but it's not the only explanation. And obviously there's a way of determining that to a large extent. But simply telling them it's not cancer is not actually by itself going to be reassuring if you're not actually saying, well, what could it be? What could account for these things? So these are sort of fundamental messages to start with. So engaging with the patient, because that's really what you've got to do here, is you're trying to engage them in helping themselves. Because up to now, a lot of it's been high-tech, and Gavin was demonstrating all that, and that's very impressive. But now the patient's got to play more of a role. So here we can remind them of things you've learnt from the assessment. You've got to remember therapeutic optimism. I know it might have died, but it is actually important that at least you look optimistic and can have a sense of hope. I think it does convey to patients. And so you can summarise what we've learnt, what we know about the pain and what's going on there. And then check the accuracy of your assessment with the patient. Do they agree or want to modify that? And I often use a diagram myself. I don't have time today to go into this, but I often just use a diagram to map it out on a bit of paper, a progress chart, and just give it to the patient at the end and say, well, after we negotiate it and agree that this is the problem. And this then identifies really what we've got to do. It's more than about pain. It's about function, about doing things. It's about mood. It's about sleep, about fatigue, and getting your body moving and so on. So there's got to be a rationale for that, and that explanation can help with that. So we need to make sure that's clear, and then plan the next step. So setting the goals is very important, and they can't just be pain relief goals, as I said earlier. So shared goals. So there's goal setting is a term that's widely used in the self-management literature, but our patients haven't read that literature, and they often don't think about goals. If they work in business, they probably do, but those who don't. But you can use examples like, saving up. Well, in the old days, you used to save up to buy a car. Getting the car was the thing you wanted. Or graduating, getting a qualification. You've got to work towards it. You can't just go down to the university and buy them. Well, not at Sydney University anyway. But anyway, so So, you know, or even thinking about preparing a family meal, you've got to do some preparation, planning and workout and so on. So those are examples of goals that would be familiar to most people. So you can, you know, give these examples. So the same applies to living with chronic pain. So people use this acronym of SMART, which just means it's specific. So don't have goals as just to be happy. That's not a goal. There's not a goal you can be very specific about because it's too vague. So walking to the shop, it's measurable. You know when you're there. It's achievable, so it's within your capacity. It's relevant to you. It's got to be important to you. And this needs to be a sort of a time frame. Like when are you going to do it? By tomorrow? By next Friday? Or when? And it's just, it really helps to focus on a goal, taking it seriously, not just, you know, this general thing, I'd like to be more active, like to do more with my family. Well, I would then say, well, what? What do you want to do more of? How would you go about that? Like going out for a meal. So when? What about next Saturday? So you just actually start to make it real. Then it's more likely to happen. And we've obtained all these photographs for our patients. So get them to think about this. It's like hanging out the washings, you know, working above, in other words, you know, above your shoulders, you know, up there on a ladder, looking rather insecure, painting the ceiling, getting down on your hands and knees, playing with your grandchild, you know, working in the garden. These are common daily things that just help to focus on. And they're all not about pain. They're about function, things that are important to people. We use charts to help people to make sure they're written down. If they can't write, we can write it in for them and check off what they're doing about achieving in each of these sorts of domains. Now, there's a toolbox of strategies which are called self-management strategies. I'm not going to go through all, but there's a lot of things to choose from. You don't have to do all of them. They can, you know, work out what might be the most appropriate for this person, like pacing their activities, problem-solving strategies, using attention, diversion, thought management, exercise and so on. So there are a lot of things that would come under this heading of self-management. So we talk about pacing, which is building things up gradually, a bit at a time. And just as the, you know, like this, it's what the dotted line is really what people do when they're what we call pain-dependent activity. So when the pain is low, they do more, and then that aggravates the pain, so then they do less. When the pain settles down, they then do more. That aggravates the pain, so then they do less, and so on. Now, you can't live much of a lifestyle like that. So you've got to try to regularise it. So we start off really low, well within their capacity, and gradually build that up. And what that means is doing less on the good days, so you'll be able to do more on the bad days. And yet, if you do it like this, you'll have less or fewer bad days. Because we've shown in our studies, you have less pain if you pace. And you use, Jenny Strong in Brisbane showed you'll use less opioids for so-called breakthrough pain of this sort if you pace. And if you don't believe it, have a look at this article in Science in 2005 by these European scientists who studied the Sherpas and how they do it. How do they climb these mountains with all this stuff on their back? About 100% of their body weight they carry on their back with those little... held on by that little cloth. And I've talked to New Zealand doctors who've been at the Hillary Hospital there, and they said they never saw anybody with back pain or neck pain. So it obviously is quite good for you to go around like this. But what they did, what this group did, was they studied them in situ, and they said, you know, they were fit and well, didn't have high body mass, but they couldn't explain physiologically how they did this. And then right at the last part of the article, they described them going off up the mountain, of climbing for 15 seconds and stopping for about 45 seconds, and then going for another 15 and stopping, and so on until they were out of sight. And immediately I read that, I knew exactly how they did it. We call that pacing. It doesn't have they were looking for a physiological explanation. I was looking for a behavioural explanation. And it was the behavioural explanation that explained how to do it. And that's what self-management is. It's a behaviour. You're trying to get people to do things in certain ways. So the Sherpas have worked this out over thousands of years, and if you want to try it yourselves, I've actually done it in the Andes myself, and it really is extremely effective. And you get to the top of the mountains, eventually, without being puffed out or tired or exhausted. So it does work. And it even works with our patients. And this is a postcard. They're not all like this. But this was a lady who had actually had back pain, and she was really not getting very far. She was just basically relying upon opioids. And I taught her how to self-manage a bit better. And she really wanted to go to the Himalayas. And she sent me this postcard, as you can see, from Nepal, and proof that if we needed more, that the treatments do work. So how did she do it? Well, she continued with a regular slow-release opiate. So they can be used effectively, providing that's not the only thing they do. But she also used all the self-management strategies that were relevant to her, particularly pacing, like the Sherpas. And she enabled herself to do it. And she did the Milford track in New Zealand, which if you've done, you'll appreciate, is not bad. But she trained herself up to do this. Of course, there are lots of options. We know from the literature available to patients that you know about. There's a website from the Cancer Council, but also the ACI. I wouldn't overlook the ACI's website for guidance for both yourselves and for patients. It's free, it's open access, and the ACI is the Agency for Clinical Innovation in New South Wales. It's part of it's associated with the Health Department, and a lot of us, myself included, are involved in the pain network for the ACI, and we've developed a lot of materials which are up there for people to go to. So that's the website. You just have to put ACI into Google. It'll come up and look for pain network. And it's become very popular throughout the world. I've met clinicians from many countries while in my travels, and a lot of them say they use it with their patients because it's been so helpful. If you need further help, multidisciplinary pain services. We're going to hear next from some experts from Peter Mac, tell us how to do it. We're gradually building up a service here at North Shore. Paul and I and the other members of the team are gradually starting to build bridges with oncology to see where we can help there. There are the resources I mentioned, and of course, if all else fails, you could try a good book. No, I'm self-promoting, of course, but I'll leave it there. Thank you.
Do we have any questions before we move on? Okay.
Great talk, thank you very much. I just had one question, like from all these self-management tools you use for chronic pain, which one you wouldn't be applying to a patient with active cancer and pain? Obviously I don't look, which out of these self-management tools you wouldn't be applying to a cancer pain patient with active cancer and pain issues?
It's a case-by-case basis, I would say. I don't think you can have a blanket statement. It depends, like what areas are affected. You may not be able to walk. That's going to affect those activities. But certainly, you can certainly look at psychological strategies wherever whatever stage people are at, and they can be very effective in dampening the distress. And helping people to keep focused on other things they need to do and keep doing things of daily life. It's pretty tough just sitting there focusing on pain all day. You're better off doing something more interesting. And so it's getting people to think about more than just pain relief. I think that principle applies all the way through. And I think Gavin really was sort of talking a little bit about that even in the post-surgical phase. If you could go out and have a cigarette, you might actually see that as a good thing. All right.
Thank you, Michael. Our next speaker is Dr. Tim Hucker to speak on the Peter Mac experience. Thank you, Tim.